minute or so for people to trickle in. I know we've been probably seeing a lot of each other lately, or whoever's been able to join. So glad to see some people joining already. Right, so in the interest of time, we'll get started. So welcome everyone to our March Pediatric Diabetes Network webinar. Before handing it over to our speaker today, I'm just going to do a land acknowledgement and some housekeeping, and then I'll hand it over to Dr. Jessica Kitchler for today's webinar. I would like to begin by acknowledging my sincere gratitude for the opportunity to live and work on this beautiful land that has been occupied by First Nations since the beginning of time. On this land, on which PCMCH operates, is the traditional territory of the Haudenosaunee, Wendat, and Anishinaabe peoples. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13, with the Mississaugas of the Credit. Toronto is now home to Indigenous peoples from across Turtle Island. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past, and we make meaningful steps towards reconciliation by building and improving relationships with First Nations, Inuit, and Métis people. Next slide, please. So just a reminder, you will be able to post any questions you have using the Q&A function, or you can use the raised your hand function, and Smita will be able to grant permission to unmute you. So when we get to the end of today's presentation, you can ask questions using either one of those things, and we'll aim to save 10 or so minutes at the end for Q&A or discussion. So without further ado, next slide, I'll hand it over to today's webinar presenter, Dr. Jessica Kitchler, who is based at the University of Windsor and brings a wealth of clinical and research knowledge related to diabetes and mental health, and we're really grateful to have her presenting today.
Excellent. Thank you. I'm going to share my screen quickly. Post. And can I get confirmation that you can see my screen?
Yeah. I think I see your presentation mode, so I think you need to do that.
I need to flip it. Sorry.
Never fails.
Never fails. We practiced it and it was just fine, right? All right, there we go. Share. There we go.
Perfect.
There it is. All right. Okay, so I appreciate the opportunity to come here and speak today and really do a two-part series. So today is going to be a little bit more of introductory and background, and then hopefully we can stimulate some questions and some conversations. And then the next session in June that I'm going to do, we can build upon this and do more clinical application of this. So my objectives for today are really threefold. One, to provide a framework for understanding the psychosocial impact of diabetes. And I'm probably reiterating things that all of you in the audience know, but it's just sort of nice to think about the framework behind all of the psychosocial and emotional work that you do as diabetes providers. And then really talk a little bit and do a deeper dive into diabetes distress versus diabetes burnout. What's the difference? What's similar? what are risk factors and how we identify it in people and how we screen for it. And then to try to have some very practical strategies and really start to lay the groundwork for that practical strategies now. And then we can loop around in a month from now and keep following up so that you walk out of here hopefully with some ideas and strategies, and maybe there are things you're already doing and it will reinforce your work, or it might be some refinement or some new ideas to help keep us energized for working with individuals who are experiencing diabetes distress or burnout. So again, the role of the diabetes provider in understanding the psychosocial impact of diabetes. We all know in this room that the impact of diabetes on persons with lived experience and persons with diabetes goes well beyond the physical aspects of having diabetes, of wearing devices, having highs and lows and treating them. There's also a tremendous amount of emotional and social impact. So emotional, the constant attention and effort, the extra steps necessary, feeling isolated or lonely, or that no one understands, or they're not surrounded by a number of people with diabetes, the burden of explaining it to other people. And then there's the social aspects of disruption to social life and feeling quote unquote normal experiences, and potentially even experiencing either actualized or even perceived stigma about diabetes status. So we know that there's a tremendous amount of psychosocial factors that go into diabetes. And there's a tremendous amount of different types of emotional reactions to diabetes. So just because a patient of yours is having an emotional reaction to diabetes, it may not be all the same. It may be that they feel a lot of anxiety or fear or worries. It may be that they feel a lot of sadness and hopelessness and sort of learned helplessness around that they can make things better. Or they might be someone who feels a lot of anger or resentment or frustration towards their diabetes. And so full credit to this for Dr. Vallis out of Dalhousie, really thinking about how we look at the different types of emotional responses and then going underneath it. Maybe those with more anxiety or fear, they see diabetes as a threat to their well-being. Those who experience more sadness in relation to their diabetes might have a perception of loss of their former self or their former healthy self, or their loss of identity. Those who are experiencing anger might have a perception of unfairness, that this is happening to them or that they have to manage this in their life. So there's a lot of different reasons why someone might be experiencing these types of different emotional responses. And as we all know, and as the CPG guidelines sort of recommend, we all want to identify concerns within our clinical practice. And the reasons why are twofold. First, which is one that we often will think of, is if we can address a lot of these psychosocial and emotional concerns, then that helps us with also managing glycemic and self-management goals around diabetes specifically. But above and beyond that is number two, is where we also want to understand the person with diabetes psychosocial adaptation to their diabetes, to just really treat patients holistically, to really help them have sort of the highest level of well-being and quality of life, somewhat regardless of its impact on glycemic and self-management goals. So above and beyond, we really want to treat people as a whole unit and not just the physical aspects of it. So I put new-ish clinical practice guidelines. They feel new because they came out in 2023 and we worked for a long time on them. I'm one of the co-authors on this, but 2023 is actually kind of almost 2 years ago now. But there is clinical practice guidelines updates that came out from 2018, and then the 2023 updates came out. And this is all about diabetes and mental health. It's open access on Diabetes Canada's website through the Canadian Journal of Diabetes. So I highly recommend downloading it, reading through it, all of those good things, because we did a major overhaul on the mental health and diabetes clinical practice guidelines with a number of different recommendations that cover screening, treatment, monitoring. However, what I often will hear is That's wonderful. That's great to have all this diabetes and mental health clinical practice guidelines and recommendations. However, we don't have enough mental health support. We don't have enough social workers. We don't have enough psychologists. We don't have enough clinical counselors. We just don't have enough. And that's true. And we know systemically that churning out and creating more mental health specialists in diabetes is should be a top priority, and I wish I could wave the magic wand that they did not give me to make more of that happen. However, in light of that, in light of sort of the limitations of our current system, Dr. Vallis did an article in the Diabetes Communicator really saying, well, beyond saying we need more mental health, which I'm not denying, what are some things that you can do within your scope of practice as a diabetes provider, as a nurse, as a dietitian, as a nurse practitioner, as a endo? What can you do as part of the diabetes clinic multidisciplinary team to really help provide some psychosocial awareness and practice, and sort of work within still your scope of practice? No one's saying you're going to become a social worker or a therapist, but within that scope of practice, how do we expand that to include sort of an awareness of the psychosocial aspects, and not just put it off as someone else can talk about that, but that can be incorporated into your everyday interactions with your patients during clinic visits. So it's very important, because what can happen if we don't, as medical providers or as diabetes providers, really take a step and say, well, what is in my scope of practice beyond dosing and CGM numbers and downloading and all of that? How can I best help my patients with diabetes meet their self-management goals, live a high quality life with diabetes, in the absence of sort of doing things and being self-aware and having self-reflection and using strategies? We can accidentally, and I'll put myself in this camp too, can accidentally get caught up in what's called miscarried helping, or helping gone awry. And this has been around for a long time. You can see the citations from 2000, but this goes on well before 2000. And this is the helper. All of us are in a helping profession for a reason. We all want to be helpers, and we want to be helpful and supportive. There's not a single one of you that goes into those diabetes clinic visits and does not want to be helpful and supportive, guaranteed. However, what can happen is how we help matters. It's not just that we want to help. It's not just matters what's our intent, but how do we execute that? So what can happen is, if we don't have that self-awareness or those skills to help in an effective way, then the helper, and I put my hand up because I sometimes fall in these traps, we can get so focused on how we think we should help that we start adding demands, doubts, criticisms. Why didn't this happen? What happened here? What about this? And then what can happen is the person with diabetes would then feel shamed and blamed by the helper. They can feel unmotivated, angry towards the helper, and angry towards the self. Now, clearly this was designed for the sort of family systems that can happen, where parents might try to help their child with diabetes, and they really start to add demands, doubts, and criticisms. But all of us as helpers, no matter what our role, we have to sort of watch ourselves, that we're not inadvertently, despite our best intentions, shaming and blaming, discouraging, and unmotivating, and paradoxically unmotivating the person with diabetes, because if it were easy, they would already have done it. There's very few people who come to clinic and say, I'm going to undermine this on purpose, and I'm going to make my diabetes worse on purpose, right? And the vast majority of people want to do well with their diabetes. And then if we layer on the shame and blame, that actually leads us to the person with diabetes increasing non-adaptive choices, meaning they're making choices that aren't necessarily in their diabetes best interests, in order to preserve autonomy, meaning they get so overwhelmed with diabetes and the shame and the blame and the negative emotions that come along with it, and all the people sort of layering that on, that they say, fine, I'm going to push it all away, because it's normal human behavior to, when something is feeling stressful and overwhelming, we all can fall into the trap of wanting to just push away whatever that stressor is. Well, unfortunately, that means you push away diabetes management. So what we have to do as providers is really think about how we might inadvertently get caught up in this miscarried helping. And don't worry, we're gonna, in a few slides, talk about how to break this cycle. But I just wanted to put out there that this miscarried helping cycle can happen in a lot of our interactions. And sort of the first step is identifying it and sort of thinking about how that might negatively impact your patient-provider relationship. So that leads us to the first poll question, which then says, what might be some potential ways that a negative patient-provider interaction, like the one I just talked about with the miscarried helping, how might that impact health and outcomes for youth with diabetes? So this is free text, whatever your thoughts are. What would be some of the negative impacts? Right. See if I can, I'm gonna minimize and see if I can see some of these answers. Ooh. Make this big real quick. All right, let me see the chat a little bit. I'm not seeing, I'm missing something here on how I can see it. Yeah,
I think
Rebecca.
we might reopen the poll just to give people another 30
Okay.
seconds or minutes there
Sure.
to answer. Oh, someone wrote in the, yeah, I think it closed. Well, just reopen it or start it
Okay.
again. So people might take a minute to type something in.
Sure. Rebecca, you had your hand up. You're welcome to, if you wanted to just verbally add it.
Hello?
Yeah.
No, go ahead, Rebecca.
Oh, sorry, I was gonna say, excuse me, the chat is disabled.
Yeah, so somehow on our webinar, how our administrative account is set up that the chat is disabled for webinars, but you can type in the Q&A or put your hand up and then we'll be able to unmute you.
Gotcha.
Yeah, okay,
Thank you.
sorry about that.
And then you can just put your answer in the poll.
Yeah, I think you can close the poll now, Smita, and see if we got some responses there.
All right. You see the poll.
Not sure what's going on here.
Yeah, I don't see the poll answer, so no.
If you click on view details and then you will see the answers, Jessica.
View details. Okay, sorry, I didn't, the view details on polls. It just says I didn't answer the question and it doesn't have anything else. I'm sorry.
Okay. Maybe if people can just write in the Q&A their response, and we'll try to figure this out for the next one. I'm not sure what's happening there.
Oh, I see someone put, Tiffany put, stop coming to diabetes appointments. Yes, that's a great example. No show to appointments, mistrust, they stop sharing information with you. Yeah, exactly. They really start to disengage. And a lot of times we'll say, oh, well, they're a no-show, or they are disengaged in their care, but honestly thinking about, well, what's our role? Stop sharing information with you. What's our role in sort of creating that environment where it doesn't feel that that's a space in which they can get help and get their needs met. There's also physical health outcomes. So Rebecca Poole and Himmelstein have done a lot of work in this world and in type 2 diabetes and patient provider negative outcomes. And they really show that when these negative interactions happen, those patients are also at risk for higher level cortisol levels, higher blood pressure, and decreased glycemic stability. So there's physical and sort of emotional and engagement impact as well. So what we want to turn our heads to is this idea of the distress and the burnout, and how do you as a provider identify this? How do you show up day after day and come to the table ready to sort of address this? Because we know it's a very common condition. And for diabetes distress and burnout, it's about a third. There's been different estimates, but in general, if you want to think about a third of individuals with type 1 diabetes in adolescence will have some significant diabetes distress. So that's a pretty high number. It's often identified more in females. The jury's out on whether it's more frequent in males or females, or if females are just more socialized to talk about it. But in general, about a third, and that's a lot of your of your daily caseload looking at diabetes distress. So you don't need to know all the details of this circular bar plot, but what the idea here is, this design on the right is really showing the words that are used to describe burnout versus distress versus depression, because you'll kind of hear a lot of those all kind of hanging together, and there is a tremendous amount of overlap. But in general, when we are trying to make the distinction between diabetes distress and diabetes burnout with depression, we really are focusing in on the negative feelings and emotions about living with and managing diabetes. So when it's diabetes specific only, but other aspects of their life are functioning okay, then we really hang our hats in the distress and burnout camp. When it does more generalized to other areas of their life of interest and focus, then it can expand and become more depression. Now, within the difference between diabetes distress and burnout, we might be just splitting hairs here, but if you hear both terms, I want to sort of spend a little bit of time separating them out. So distress is really focused on the emotional aspect, the stress experienced by the person with diabetes. They feel burdened, they feel challenged by diabetes care, they may have ongoing worry. So it really sticks to the emotional piece of it and doesn't sort of bleed over into the behavioral aspects of it yet. And so diabetes burnout is when those distressed feelings and emotions, they feel mentally, emotionally, and physically exhausted because of diabetes, and then that plays out in difficulty with diabetes care. So that might be the avoidance, that might be the canceling of diabetes appointments, that might be the not changing the sets as frequently as they're recommended to do so, detachment from support systems because they feel powerless and hopeless about diabetes. So diabetes distress is really the emotional piece, and burnout includes the emotional piece and adds, then it impacts some of the behavioral outcomes and engagement. Now, we know there's a number of risk factors for diabetes distress. And some of these risk factors we cannot control. We can't magically make all of these different, but there are some pieces that we can address in sort of our role within this. And I also wanted to highlight that a lot of times some people might say, well, if they would just get on technology, right? And I'm a huge proponent of technology. I love technology. I wear technology and all of that. But at the same time, what we want to be careful of is that we also know that different people have different responses to technology. And so Molly Tannenbaum out in Stanford, she has this great study. It's cited at the bottom if you're interested. And it's entitled From Wary Wearers to De-Embracers, Personas of Readiness to Use Diabetes Devices. And so the take-home message from her article is that there's actually 5 clusters of patients. I almost think of them as like patient trajectories. And the vast majority are people who they labeled as de-embracers. They had sort of a positive attitude and not a lot of barriers to getting technology. Then there were the free rangers, where they had more of a negative attitude about technology. They were nervous to trust it. They wanted their old ways of doing things. There's data minimalists. They don't want more information about diabetes. They go on their sort of the art of diabetes and their gut of diabetes and their long history of managing it. There might be wary wearers, where they don't want the attention from others, and wearing a device just brings extra social stigma for them. Or the very high distress, where they have a lot of different barriers. And so we have to think about trying to push technology on some people that fall into the categories other than the de-embracers may have some unintended consequences. So we want to really think about their readiness to adopt and adapt to new diabetes technology, because there might be additional technology risk factors that increase diabetes distress. So instead of just assuming that diabetes distress will be relieved by wearing technology because there'll be less burden, there is other burden. There are more alarms, there's more pump failures, there's more CGM pod failures, all the things. And there may be some more distress over a lack of access. Maybe they're a de-embracer and they would like to wear it, but they've aged out in certain provinces, or they don't have, or it's cost prohibitive, or whatever it is, from a financial point of view. So you want to be very clear that diabetes distress is not simply going to be relieved by technology. And we also want to make sure that we don't add to that miscarried helping by having our laser focus being on technology as the solution, because we may inadvertently shame and blame them for not choosing technology, or we may spend most of our time trying to convince them to wear a pump or a CGM, instead of sort of understanding where their hesitancy is and maybe how we can move them forward. Or we can also engage in some shame and blame if they have all the technology and their glycemic levels aren't in target or below our target ranges. They can sort of feel even more shame and blame from us, because technology is not a panacea that magically makes diabetes distress go away, as you all well know. So we want to take all of those pieces into mind, and you may be a clinic that already does screen for diabetes distress. If you are, that's wonderful and amazing. If you're a clinic that's thinking about it, or if you do it on an ad hoc basis, I just wanted to throw out here the different types of diabetes distress scales. And then my next slide will have the links to it. And so all of this becomes available on the website, so you can go there. I've pulled all of the links for you, so if you're interested in looking at them. So there's the diabetes distress scale, the DDS, that's been around for about 20 years. Fisher and Polonsky, that's sort of the tried and true one that's been around for a long time and has been used down into the sort of adolescent range. They recently had the diabetes distress assessment scale come out in 2024. Where they've shortened it. So there's 8 plus 22. That means there's 8 items to measure diabetes distress. And then there's 22 items to identify the source of the diabetes distress. Because we all know from like an iceberg metaphor that you might have diabetes distress score, but where it's coming from and what's driving that is different for different people. So I think that's kind of an interesting new way to look at it. And they have that for type 1 and type 2. And then there's the problem areas and diabetes scale, or the PAID, and the PAID has adult, child and teen, parent, and pediatric versions. And so if at all, I'm not going to spend too much time going into all of the different pros and cons. There's so many different ones out there, but I do have the links for the DDS and the DDAS. If they have all of the versions, and they're in French Canadian and in English, and they have their citations there. And then from the PAID perspective, I have the link there if you wanted the adult, pediatric, child, and parent of child versions. And then I have a link to article for the teen and parent version of the paid, you need to email the author directly and sign a release form. And I have the link to that website. Not that website, that article that has Dr. Jill Weiss Provincial's email. So if that's something of interest to you. So these are all the different links and citations for it. So let's say you've screened, you're pretty clear, you know that there's diabetes distress. And now what do we do with it within the scope of your practice, right? Because the Diabetes and Mental Health Clinical Practice Guidelines outlined a number of grade A evidence. So all of these treatment modalities listed here on the screen are all from the CPG guidelines, and they all have grade A level evidence base behind them to justify using them for diabetes distress. Now, obviously, you are not going to all become cognitive behavioral therapists or acceptance and commitment therapy therapists. But you might engage in stress management, coping, some coping skills, case management, and then motivational interviewing. So motivational interviewing is something you may have heard of before. You may have taken workshops on it. And so I'm going to spend a little bit of time talking a little bit about how we can integrate, not that you're going to become a therapist doing motivational interviewing, but how can we integrate some of the core concepts into how you interact and engage with your patients. So we're going to try a poll. This one will be easier, hopefully. Scale of 1 to 10. I'll just have to look at numbers. And so we'll open up that poll and see how people feel on that. How familiar are you with motivational interviewing approaches? I just want to get a read of the room. All right. Oh, good. It worked. I got it. Okay. So we've got we have some clusters. So we have some people at 9 and 10 who definitely feel like they have a lot of it. Some middle of the road, 4 to 7, and then a couple people on sort of the lower end. So I'm going to sort of teach to this broad level, and then in June, the idea is to sort of do an even deeper dive for people. Okay, so let me open that back up. Oh, I just did something. Oh, I unshared my video. There we go. Okay, so now what I want to do is shift over to some practical ways that you can approach diabetes distress in your clinic. So just to remember that a lot of motivational interviewing and a lot of this talk that we're going to talk about on patient-provider relationships comes from this idea of self-determination theory. And so I won't get too cerebral here with theories, but self-determination theory is really a motivation theory on how individuals are motivated to sort of achieve the highest well-being, physical, mental, otherwise. And that all of us humans, we are motivated when we sort of have these 3 psychological needs met. So when we feel connected to whatever we are having to work on. So whether this is motivation to learn a new language, whether this is motivation to, take care of your diabetes, whether this is motivation to clean your house, right? So this motivation now to do larger healthcare behaviors or larger sort of goals that you might have for your life. Some of the ways that really help are if you can feel a connection to other people who have a similar condition or have a similar situation that they're in. If you feel a sense of competence, that you feel like I can do this, I can have mastery over this. If I try, I will have some positive outcomes. I will learn that language. I will see some impact on my diabetes levels and all of those kinds of things. And do I have autonomy? Do I have a sense of feeling in control, that I'm making these choices for myself, that I'm feeling empowered to make these decisions and not that I'm doing them because someone else to sort of shame and blaming me into them. And so we know that all of us humans, we feel the most motivated when these three constructs are happening. So what we want to think about is, what are we doing in our patient-provider interactions that is demonstrating connectedness to our patients, giving them a sense of competence, that we believe in them, that we believe that they can do it, and that there can be some positive outcomes that come from it, and to empower them to make some of their own decisions and to make this decision for themselves. Because if they're changing for us or to please us, that might change on the short term, but in the long term, when we're not there, when we're not at that clinic visit, all the other 90% of the time that they're not in the medical clinic setting, who's going to motivate them? It's going to have to come from within. So we want to make sure that that miscarried helping turns into effective helping. And so that effective helping is that the same helper who wants to be helpful and supportive asks how they can be helpful. They actively listen and respond with potential suggestions so that the person with diabetes feels empowered, heard, motivated. They see their helper as part of their team, and that they believe in themselves and have that self-efficacy or that competence. And so then that creates the person with diabetes having more motivation to take a more active role in their diabetes care decisions, feel more comfortable in communicating their needs, not withholding, like we talked about in poll number 1, not holding back setbacks or vulnerabilities, that they see this as, I'm going to bring you the ugly stuff, the stuff that didn't go well, so that we can work on this as a team. Versus if they don't feel that that's a place where they can be vulnerable, they're going to hold that back. And so you're not actually going to be able to be as effective as a helper. So engaging in these patient-centered conversations do not have to be on top of all of the check boxes you have to do at your multidisciplinary clinics or all the other things that you're doing. These are ways that you are using the current conversations that you are already doing and really making sure that you're flipping the focus so that it's about the patient's responses, their concerns, and your readiness to have a repertoire of ideas and suggestions and advice should they ask for it and want that help from you. So there's some different approaches to doing this. There's the shared decision making, where you make an effort to align your goals with what they hope to achieve. Like I said, you have this repertoire of strategies. You might be able to sort of tackle it. It may not always be one size fits all. Think of it as like your toolbox. Sometimes you need a hammer, sometimes you need a screwdriver, sometimes you need a wrench. That's the extent of my knowledge on that topic. But you don't want to always choose one tool and say, oh, a hammer is going to work for everyone in all times. And you want to use motivational interviewing to really build on that person's intrinsic level of motivation and readiness to change, so that people talk themselves into the next course of action. So I'm going to start shifting the word away from motivational interviewing to motivational communication. And so the 4th edition of the motivational interviewing book really talks about shifting this terminology. So motivational interviewing is really sort of reserved for people who are doing the therapy, in it and for a longer period of time. But this motivational communication is sort of the spirit of motivational interviewing, where you use good rapport and you resolve ambivalence that we all experience, and we use a sort of a communication style in how we interact and approach and talk to our patients as a way to build these patient-provider encounters to feel more supportive, to feel more helpful, so that they can reach their own self-management goals. So the idea behind motivational communication is that we really want to look towards guiding most of the time. There will be times in which we do directive, we give advice, we are a little bit more active and directive. And there's definitely times when we're going to be a little bit more following, you're going to be a little bit more empathetic listening. But I think motivational communication gets sort of a bad rap of it's very passive. It's a very active, it's guiding, it's thought to provide the best outcomes. And it really is about nudging them and empowering them towards change without being too directive and without being too following, because we know that all of us experience ambivalence. All of us should perfectly always exercise our certain number and eat this and do that. Ambivalence is a part of the human condition. So all of us have reasons not to change a behavior that maybe we know we should. I always put should in quotes because we should on each other. And just to acknowledge ambivalence does not mean that someone has pathology or that someone is characterologically flawed because of ambivalence, because we all have ambivalence. And so change is easier to happen when we can explore and clarify, resolve that ambivalence, where we have the opportunity to say it is hard to give up familiar behavioral habits, even if we know that they lead to outcomes we don't necessarily want. Familiarity is something that's hard to change. So we want to make sure we acknowledge that ambivalence. So what I want to talk about a little bit today in these last few minutes before we move over to the Q&A piece is to think about how do you guide. It's all well and good to say, directive, following, guiding. There's really 3 core skills that I want to introduce today, and then I want to get some feedback on how on maybe some cases that we could apply it to, because I think that's what really helps the most. And so there's 3 core skills. There's asking, active listening, and informing. And the thing about motivational communication is that it can feel deceptively simple. You read this on a screen and you're thinking, yep, I ask, I actively listen, I inform with permission. But when you actually go in and start practicing it and doing it, it can be a lot harder. And I remember this when I was a motivational interviewing therapist for a grant. So I had to be very, very by the book, and I had to have all my prompts, because there's something about how we're socialized to communicate in which these don't always come naturally. And so we have to make sure that we are asking using open-ended questions so that the patient does most of the talking. And it really allows the patient to think out loud and to process out loud, and that we're engaging in the active listening. And these are called affirmations, reflections, and summaries. I have some of those deeper dives for next time for the case studies, but I'll talk about them a little bit more in the next slide. And what those affirmations, reflections, and summaries do is they show that active listening, that you want to understand what they're saying. You want to double check what you think you heard, and it opens the door for the people to keep talking about what's bothering them, what's going on. And then we save informing for last. And that's where we can provide advice, we can provide information, avoiding lecturing, and what we call resist the writing reflex. And that's where we try to say, oh, well, here's the right way to think about it, or here's the right way to do this, or here's the one right way to handle the situation. And that if we want to give advice, we're going to ask for permission first. And I'll have some more at the next one on this ask, offer, ask approach, where you ask for permission, you offer the advice, and you ask what they thought about your advice. And so there are 3 main skills that you can use. There's a quick mnemonic called the ORS. And so if you look at open-ended, affirmations, reflections, and summaries, those are your ORS skills. And what your ORS skills, like I just said, if you want to spend the vast majority of your conversation, again, 5 minutes, 7 minutes, whatever you're doing to have that conversation about how they're doing, what you can work on for that day, asking an open-ended question followed by 2 to 3 affirmations or reflections. So it's kind of a 1 open-ended question, 2 or 3, thank you for sharing that. What I think I hear you saying is this, this, and this. So you're reflecting back what you think you heard, rather than immediately going into your answer, and taking that time to slow down and reflect what you heard, and then getting their agreement that you understood it. So this is called the OR skills, and then you summarize at the end. So what I hear we're going to work on today is this, this, and this. So I want to introduce those OR skills, and this article is not about diabetes. It's about a family healthcare provider talking to someone about their drinking, but you can still get the ideas of the ORs, and we'll do a deeper dive next time. So some of the basic skills during a clinic visit that can go so long in disrupting that miscarried helping cycle is to really build that rapport, that working alliance, simple things like making eye contact. We all have that computer in front of us, right? taking that moment to look up from the screen, say supportive statements, be empathetic to the situation, engage in those active listening skills, and involve them in that decision making, that shared decision making. Well, we could do this or this. What do you think? Get an agenda. What would you like to discuss today? We could discuss X, Y, or Z. I'd like to know what's important for you to discuss. You could also use what's called scaling questions. How confident are you? Like after you've summarized, they're going to walk away and they're going to work on changing their CGM the first time it goes out, and not wait a day or two to put a new CGM in. I'm just making something up. How confident are you that you can do this? It sort of doesn't matter where they put themselves on the scale. They can put themselves anywhere. It's just a subjective scale. And you can say, okay, what brought you up to a 4? What would it take to get you closer to a 9 or a 10? So you could really talk to them about what their confidence is and what is it that's pushing them towards it, and what are some of the barriers to get in the way. And you can get a quick confidence assessment there. And so there's in motivational interviewing, 4 tasks. And so if you can think about clinic visits as being engaging, joining with the patient, highlighting their successes, starting off with, if you can say nothing else, learn this from an amazing social worker. If you can say nothing else, thank you for coming here today, right? Because we know a lot of people will disengage or cancel from appointments when they don't feel like they're helpful. So if you have someone who came anyways, if you can thank them for coming and joining and overcoming maybe all of the barriers that it took to get off of work or to take a bus or do whatever it takes to be there. Then focus in using your ORs. What can we work on today? What would be helpful? We could do X, Y, and Z. Ask permission before giving advice. You can get involved in problem solving, goal setting. Again, that very patient-centered approach. And then closing with a summary. What will they be willing to do? How will they measure success and effort? So this 4 pieces to your clinic visit are actually quite a useful approach to setting up some self-management behavior goals. And so what I'd like to do there, we're going to end with a quote. And so you can't, it's cut off a little. You can't stop the waves, but you can learn to surf. So how are we helping our patients learn to surf rather than shaming and blaming them for not knowing how to surf or not surfing very well or not feeling like surfing or not feeling motivated towards it, so that we can help move them towards a stage of acceptance where they learn to coexist with maybe the unwanted aspects of diabetes and also learn to thrive with it. So I also will have some additional resources here. Some books. In full disclosure, from like a bias, I was a co-author on this workbook. It's called the Type 1 Diabetes and Mental Health Workbook. It is an ADA book, but I think it's very applicable. Here in Canada, the Breakthrough T1D, Canada Mental Health and Diabetes Training. There's a link here where if you're more interested in learning more about mental health treatment within your scope of practice as a medical provider, or diabetes provider, we have a curriculum that we created that you can take and learn even more deeper dive. You're going to hear my voice again on that one too. In full disclosure, there's a diabetes and mental health conference that's coming up in May in a year from now. There's a website. We actually have a talk tonight. Adam Brown is going to be a talk. I'm hosting that one, so I get to use my Zoom skills as the host. And so we have one that's all on diabetes and mental health, and it's all virtual. And then the Breakthrough T1D Canada also has the mental health and diabetes directory. So after people with mental health registration, so the first thing I talked about was a training for healthcare providers. What we also have is we have the sister curriculum for individuals who have mental health training and background. There's psychologists, psychiatrists, counselors, social workers. They can take the curriculum to learn more about diabetes. Now, you all wouldn't take that because it's more for general mental health providers to learn more about diabetes specific mental health interventions. And then once they take that course and they do the live feedback, they are listed on the diabetes directory. And so you can go in there and plug in the zip code and see who is on that. And not JDRF, sorry, Breakthrough T1D Canada manages and maintains that directory. And then, of course, there's diabetes camps, which all of you are very well aware of. So I will stop there and I will open it up to questions and discussions. Also, knowing that I would love for people to let me know. I want to take those OR skills and do a deeper dive. And I have 2 case studies ready to go from a fear of hypos and a fear of hypers. But I don't have to use that if other people have other cases that they would like me to implement some of these with and discuss in more detail.
Amazing. Thanks so much, Jessica. So I'll open it up for questions, comments, and I see there's already 2 questions, comments, one from Jennifer saying not a question, but a thank you for this great talk. And then I see a longer question comment here. So Jessica, if you can see that, I want to answer that question.
I know. Oh, the no-show fee. Yeah, it's all the, okay. So how to manage no-shows. Your preference is to call the client to discuss. Our clinic's considering a no-show fee. And it Leary, just to add insult to injury, and just one more reason not to come, right? Or if then they just won't reschedule, right? Because they're so worried about the fee. That approach to encouraging attendance and the ethics benefits risks. No-show fees. So yes, that is a very good question. We tended to fall in the category of how we handled it. Again, we wrestled with this a lot, is to not actually have a fee right away, that you had sort of a couple of opportunities to not come and not show. And then when there was a fee, it was a fairly nominal fee. So I'll just use my own example. My dentist does a $100 no-show fee and cancellation less than 24 hours. And I was like, my goodness. So when we've done it, it's been like around $10. So it's enough of a barrier, but it's not, $100. But I think it adds insult to injury. I think from a provider client relationship point of view, it can add insult to injury. However, on the flip side, having a 30% cancel and no show rate blocks other people from getting in as well. So there are 2 sides to that coin. So I tended to land of the sort of, you get 3 opportunity, like how we set our policy is like you have 3 opportunities to have same day cancel or no show, and then the nominal fee went in, so that then is a more of a pattern. And then there was times that we could like call them and engage them and see what was going on and what were the barriers, and we could work with them before it was like a one and done. And then even then the fee wasn't super high, and then we would explain that it's also about access for other people. So and then Tiffany shared an online, yes, MI by Stephen Rolnick, the father of motivational interviewing. They have lots and lots of free websites and workshops and things like that. So thank you, Tiffany, for providing that. And what I can do at the next one, that's a good one. I'll spend my resources page adding links to not just the motivational and not just the mental health training here in Canada, but also just the motivational interviewing website that has all kinds of different workshops and things that are more general. All right.
Tiffany has another question in the Q&A.
Okay, so it says, I struggle. Things are important to discuss for preparedness, but not important to the patient at the moment or ever until it's too late. This is especially true with my young adults. Eventually, we need to discuss this. What's your approach? I find this is a backburner item until hospital admission. Okay, great. So this is a perfect situation in which a perfect way to say that this is about guiding this, a more following way would say, okay, they never want to talk about it, so therefore we're never going to talk about it. So what you can do, that's a very motivational communication centric way, is to say one of the topics that we need to talk about at some point is this. Would you like to talk about it today or next time, right? And so you can still put parameters. You can still put these sort of, you know how we do with toddlers, right? You can have the blue socks or the purple socks. So you can still say, you know, we need to address these things as part of this, but they have some control over how would you like to talk about it. And if they say, I don't need to talk about it, then that's the perfect in from a motivational interviewing to say, so you're not going to talk about the details of it, but now you're going to move into a little bit of the process. What is it about that topic that you feel like you don't want to talk about? Or what do you know about that topic already? Or where do you feel like you get your information on that? Or what's stopping you from talking about that? Or what is it about that topic that makes you think that this isn't going to be helpful? So as soon as they give you that the hesitancy, take that step back and say, all right, can we talk about where that hesitancy is coming from and what is that? Maybe they have a whole bunch of knowledge, which they probably don't, but you know, maybe they feel like they have a whole bunch of knowledge, or maybe they feel like the influencers tell them, or whatever it is. Then you'll understand where the hesitancy is coming from, like an iceberg, right? They say no thanks, but no thanks. And so you don't want to completely follow and say, okay, they said thanks, but no thanks, so I'm never going to talk about this until they're in a really severe decay. You can back that step up and say, what is it about that topic that makes you hesitant? Or what is it about that topic that you don't feel like we need to talk about? Or how do you feel like, what's going on basically there? Why is that something that is not interesting to you to talk about? Because I want to hear about that. And maybe you'll get a little bit more, and then you can say, they think, oh, I have all the answers, or it's never going to happen to me, or I'm healthy, especially young adults, right? Because developmentally, this is like that quote unquote healthiest time of their life. But so they might fall into that thought process that nothing bad will happen, right? The risk assessment and all that, but then you'll get the information and not just passively stop. And then you can say, well, at some point, third person, we have to talk about it, but you get to control a little bit more about what would be of that. Is there one piece of it that would be more interesting or more useful to you or more helpful? Or if they say, oh, I know all the information, you can then say, well, help me understand, what would you tell other people? And so always making it kind of a third person can be helpful too. So that's where I tend to go when you get that, like, thanks, but no thanks. And they're very polite about it oftentimes. No thanks, but no thanks. But dial that back and then process why they're not interested in that. And that might get you more information.
Great. Thanks so much, Jessica. I see a few people have already hopped off. We have 2 more minutes if anyone has a final question, but just a reminder that Smita has put the evaluation survey link in the chat. So we'd appreciate if those who joined could do that. And a reminder, Jessica will be back for part 2 in just over a month from now. So I'll send out an email reminder about that. I feel like there's probably a lot of resources we can share from your presentation today. So we'll share those in the email as well. And just a reminder that we're also looking for volunteers from PDEPs across the province if anyone is interested in presenting or leading complex case rounds. Probably the next one would be in the fall or the winter. So please reach out. And as always, thanks so much for joining us over your lunch hour. And I hope everyone has a nice day. And hopefully everyone who's joining today has some sunshine and has some time to enjoy it today. Thanks so much, everybody.
Thank you.